Okay, I think we should be live.
Yes, we
Welcome,
are live.
everybody. All right, excellent. Okay, so we have just a jam-packed live stream today. I'm super excited about it. I know a lot of people were really interested in the topic today. And just as a quick disclaimer, while this is more of, I think, a clinician's episode than the other ones that we've had, for any clients that might be watching and in distress, we have to have a reminder that this is not a substitute for therapy. If you're in any kind of mental health distress, you have to seek out a licensed mental health professional. If you're in critical distress here in the United States, you dial 911 or go to your nearest emergency room. Okay, so let's start off with introductions. So we have with us Dr. Marty Franklin, who's been with us before. And I feel like we have like a little East Coast, West Coast thing.
I'm in the middle.
So I know that's right. So Marty Franklin, clinical psychologist, leading expert in OCD and anxiety disorders. He serves as the executive director for OCD and anxiety services at Rogers Behavioral Health, associate professor emeritus at University of Pennsylvania, 260 plus publications, and really considered one of the world's experts, particularly in pediatric OCD, but all things OCD. And then we have Dr. Mike Treanor, incredible researcher, and in my opinion, Mike, you're author on some of the articles that I think are kind of the hottest in the field right now, that are sparking maybe the most interest, the most debate, that are very frequently cited. Mike Treanor comes to us from UCLA, the UCLA Anxiety and Depression Research Center, headed by Dr. Michelle Craske, where his research examines, and this is what we'll be talking about today, Pavlovian extinction learning as a mechanism of exposure therapy. He's also an attending with the UCLA Child OCD clinic, and he's the owner of the California Center for Anxiety and Traumatic Stress, where he works with patients. And he also offers consultation with other mental health professionals, and he has consulted with our group before a couple times. And so happy to have both of you here. And of course, my co-host, Zach Pesha, who is a social worker. Zach is in Iowa and Minnesota, right? Zach is a wonderful, broad-based clinician and OCD expert in his own right. Thanks, Zach, for being here today with me to support me in this. And I'm Dr.
Awesome.
Katie
Lucky
Mineta.
to be here.
Got a practice in Long Beach, and I just love doing this because I think it's so fun. I always learn something when we do this, and hopefully we can all, bring it back to the other clinicians that we consult with, and also to our clients that we work with. All right, so we're gonna get started. Any other preambles? Did I miss anything, guys? No? Good to go. All right, good. All right, let me make sure I have access to the chat. Just to let everybody know, I'm gonna be attempting to monitor the chat here. I already see we kind of, oh yeah, we're up on the chat. All right. So I think the first thing that we have to talk about that I think people mistake a lot of is that when they see the title of that 2014 article and they see, optimization of exposure, they're like, oh, I want to optimize my exposures, right? And so they read that article, and I think their assumption is that they can just take all of the principles that you outline and immediately apply them to any exposure that they're doing. So let's talk about what specifically that article talks about Pavlovian exposures and sort of what's in that, what is sort of it's directed at and what it's not directed at. Let's talk about that first. And Mike, I'd love to hear from you.
Sure. So there's just to kind of bring it back, Michelle published the first article in 2008 when I was in grad school, and really it was kind of a call to return to some of the science of predictive learning, Pavlovian learning, not because that's been completely ignored, but the argument was that hasn't been at the forefront in the way that it used to be. And she was kind of calling back to, hey, let's sort of pay attention to this again. Then there was the update we did in 2014 And then another update in 2022, and we just recently published the first RCT, kind of looking at some stuff, and along the way, a bunch of like laboratory and analog studies and everything. And yeah, certainly, I don't think Michelle's argument in 2008 or our argument in 2014 or 2022 is that, one, this is not the only way of doing exposure. There's a lot of different ways of doing exposure. And we weren't suggesting and aren't suggesting like that even when this applies, this is the only mechanism. I think Michelle's interest and my interest is more just in trying to understand if we are able to sort of optimally target a given mechanism, like what happens? Do things improve? Do things kind of not? Are things equal? I mean, that's an open empirical question. And so part of what we were thinking is that if we're being honest, a lot of ways of doing exposure currently and that have been going on for a long period of time are just an amalgamation of different techniques a little bit and different processes and theories. And they're clearly effective, but we also have reached, there's somewhat that efficacy ceiling where everything's really good, but there's still a gap. You know, Dave Tolan did some of this work, and depending upon your criteria of like remission or improved or anything, you know, 50, 60%, there's still some room to grow. And so maybe if we isolate some of these mechanisms a little bit more, like what happens? And so we weren't saying that this applies all the time. We weren't saying this is the only mechanism. We're just kind of like, for a lot of different anxiety disorders, this might be a principal mechanism. And what happens if we directly target it a little bit more? So that's kind of like the disclaimer I wanted to start with. Not
Can I want to add something to that
yeah.
because nerd alert, I read the 2008 article last night.
Awesome. Great. Yeah.
And
yeah,
what's that?
it's still relevant.
fresh.
Yeah, it's great.
It is. It totally is. And I was impressed because it's exactly what you were talking about. I think more likely than not, I bet there's probably actually a handful of people who actually read it. And then there's people who have talked to those people and then, you know, give them a telephone, it's gotten watered down. So, because it spells it out very nicely, and that on one hand, we know what works here, habituation, and here's the evidence that actually supports it. And on the other hand, here's what we started knowing with, you know, inhibitory learning. And it fully states that this is what could support that. These are the theories that are behind this, and it's not everything. So like,
Sure.
I think all of you are right in that this isn't about what's right, what's wrong, or anything like that. This is just about finding more and more answers. And if anything, it just made me think like, wow, we still have a lot we need to figure out.
Sure.
We still have a lot more we want to research, which is fascinating and exciting to me.
I would agree.
Yeah. And I want to just point out one thing that, you know, that I've seen therapists do, I've seen other clinicians do, I've seen articles published where people do this, that they'll say they're doing inhibitory learning, they're tapping the principles of inhibitory learning, and they'll say they'll make this, they'll have clients make that statement, that sort of prediction, and then sort of looking at the outcome, but the prediction will be, I predict I won't be able to cope.
Yeah.
Now, Mike, tell us, why is that not right for inhibitory learning?
So I want to answer that question and your first question. I was just kind of doing the disclaimer, and like, I'm not trying to like fight anybody out there on the live stream or kind of argue. It's really just, you know, this. But so when we talk about a Pavlovian association, sort of what I would call Pavlovian association is a predictive association between a stimulus, which we call a conditional stimulus, and an outcome, which we call, or is called, an unconditional stimulus. So that's kind of and that the strength of the predictive relationship changes on a trial by trial basis, based upon the discrepancy between what is predicted and what actually happens. So strength.
Can I ask a question about what the one piece you just said? So you said based on the discrepancy.
Yeah.
Are we saying that that part can change and is variable with every single trial?
Yes. So it does.
Okay.
And that's one of the things.
Just want to make sure I understood that right.
yeah, changes. It can change on every trial, every exposure trial, and you're in the lab, every conditioning or extinction trial, depending how different the outcome is from what was predicted by it, right?
Mm-hmm.
Then there are other factors that influence this type of learning that are part of Pavlovian learning, which are things we call like the attentional salience of different stuff, the overall, jargony terms about the associability of the CS and the US and stuff we don't have to, get into too much. And the predictive strength of all the variables that are present that the person or the organism is aware of, those all influence the amount of change that happens. So I'm saying this because Pavlovian learning isn't the only type of predictive or causal learning that humans or non-human animals engage in. It's just a particular type. So not all expectations are Pavlovian in nature. So I might have a prediction about who's going to win, let's say, a local election. There's no evidence nor plausible reason to suggest that that's Pavlovian. Maybe there's other rules and inferences I, kind of use to make that prediction. And I'm not a cognitive psychologist, but there's debate and there's a lot of investigation and theories about different types of predictive and causal learning, and Pavlovian is only one of them. The reason that's important is because the strategies that we're talking about in the inhibitory retrieval model are translational strategies directly based in Pavlovian learning. And so if you're not targeting Pavlovian learning, I don't know if these strategies are going to work, right? So the strategies that we're talking about are derived from the basic science, and you're going beyond the science when you start doing that. And so I'm saying like, hold on, maybe, but you got to kind of do the research first.
Right.
So before we kind of get to
So that statement, right?
Yeah.
I won't be able to cope, or my feelings will be unmanageable.
So that is kind of the second sort of, so that's the definition of Pavlovian learning. And then we've added further kind of criteria just to kind of like push people in what we think is the right direction, was that the outcome has to be what we call biologically significant. So things that you think are like we're evolutionarily adapted for: social rejection, physical pain, physical illness, bad things happening, to us or our loved one. The reason for that is that the vast majority of our research, the field's research on Pavlovian learning, is with those biologically significant outcomes. So again, we're trying to stay conservative to what we know. And even though humans can form this type of relationship with non-biologically significant outcomes, I don't think there's much plausible reason to suspect in psychopathology and anxiety disorders, OCD, when there is a Pavlovian sort of element, that the biological outcome isn't the most important to sort of change. So again, social rejection and social anxiety disorder, in certain types of OCD, contamination or physical illness, harming a loved one or harming self, and other subtypes of OCD. Even if there's another outcome that's Pavlovian, if you change that or get rid of that, and the biological one is still in place, I think the person's still going to be pretty distressed and impaired. And so we're trying to encourage people, like, think biologically significant when you're trying to do extinction. To kind of, and I'll shut up pretty soon, but then that
this
Interesting.
This is really helpful already, like, honestly.
I can't cope with it is not currently part of our model, what we would consider a viable outcome. It might be. You got to do more research. Somebody's got to show me that that exists and changes in a Pavlovian manner. I'm skeptical that it is a Pavlovian outcome for a variety of reasons, and part of because of all this confusion. Michelle and I are writing a paper right now when we're going to try and kind of clarify it even more. We've talked a little bit about it in other papers, but we know there's a lot of misunderstandings, so we're going to try and lay it all out, kind of like why we don't do that. So it's too much to get into here, but for right now, if you're a researcher or a clinician and you're saying, I can't cope with it, or how long will I remain in the exposure, great. That might be helpful. It is not part of the inhibitory retrieval model as is. It's not. So that's kind of the party line for sure.
Let me back up a little bit, primarily because I'm old. So this is a paper that came out in 1986, Foa and Kozak, which was basically
Marty, I was 6 years old. I just want to point out.
Yeah, and I was just out of college and forced to read it as a graduate student. I didn't understand it the first time. The 35th time, I think I did. So basically, the idea there was that Malware, two-factor theory. Obsessions give rise to anxiety, compulsions reduce it. Therefore, you're irrespective of why you have obsessions. He was agnostic about that. But what he would say is your treatment basically shouldn't target the obsessions, it should target the responses. So the compulsion. So treatment basically becomes reduce avoidance behavior, and then that's going to provide opportunities for the person to learn that they don't need to rely on them. So it made sense. But I think that Foe and Kozak and a lot of other people in the field were dissatisfied that it didn't address anxious cognition as much as they would like. So the emotional processing of fear, exposure to corrective information, 1986. So this idea that the emotional processing folks are sitting there waiting for habituation, in 1986, it was really explicit in that that was not necessarily the primary outcome. Exposure to corrective information, meaning we do exposures in such a way that provide you an opportunity to test your beliefs. And lo and behold, if your beliefs turn out to not be true, then we are happy that you have changed your thinking. Within session habituation at the time was considered one of the ways that you would know that was happening. The other way you would know is
like
between
a
session
marker,
habituation.
right?
Right.
Yeah.
And so, but any good theorist should be open to changing their minds in response to data. And somewhere in the mid-2000s, I believe it was Agnes Van Minnen, among others, found that within session habituation predicted nothing. Between session habituation predicted stuff. Within session habituation was not so useful. And so when you read more modernized versions of emotional processing theory, you'll notice that got dropped out, in part because it just wasn't predictive. And that's what good theory should be. It should be amenable to change based on data. So this idea that I got this once that I was giving a lecture. This is 2010. I think it was at ABC Toronto. I was doing a live demo of an exposure with a teenager who was afraid of contamination and public toilets specifically. I had 200 people in the room, and I'm doing this demo, and there's one person. At this point in my life, you can find the one person who disagrees with you, and she was really obviously angry with me. And I was doing my demo. I was doing my usual thing, trying to keep this kid engaged. She got pretty upset with me and started swearing at me like a long-haul trucker, which is always fun. And my research assistant was playing the role, but she knew the case. And so I got her calmed down. I got her to do the exposure. We got to learn stuff by touching the toilet and rubbing it all over ourselves. And at the end of my demo, this woman physically pushed someone out of the way so she could be the first person to the microphone. And she says, Dr. Franklin, I found during your demonstration session of exposure that you were, how can I put this, quite chatty. And then she said, when I learned behavior therapy, I was told to simply be quiet so I don't interfere with habituation and ask them for their SUDs every couple of minutes. So I didn't even know if you asked her about her SUDs. What do you make of that? It's fabulous. And okay, I've got to respond to this. And I said, okay, so would you mind telling me when you were trained in behavior therapy? And then she said, well, I was trained in the late 70s by Dr. Donald Meichenbaum himself. All proud of herself. And I said, well, all I can tell you is this. There's been quite a few developments in the field during this interim period. And then I explained what they were. And I said, look, we have to remember this is an interpersonal interaction with a teenager. How do you think that's going to go if I'm sitting here in silence, asking her every 2 to 5 minutes what her SUDs are? I'm going to lose her. So I have to pay attention to that interpersonal context. And what I was shooting for was I think I probably looked like I was doing inhibitory learning. I asked her, what do you think is going to happen if you touch the toilet? Oh, we're going to be thrown up within 15 minutes. Cool. Okay. So instead of trying to talk her out of it, so I guess the best way to figure that out is to test it using the very language out of Michael's paper. And so we did it, and we weren't throwing up. and her anxiety began to come down. I wasn't harping on it. I was noticing it. And I said, well, what do you make of the fact that we're sitting here in half an hour and you're kind of starting to look bored to me? So you thought you thought you'd be throwing up. B, I don't think boredom was one of the things that you thought would occur. Why are you bored? And she said, because the bad stuff I was afraid would happen didn't happen. So, well, I'll be damned. I wonder if that suggests something to you going forward. Maybe you should try this again. I'm not giving, this is intolerance or uncertainty. I'm not giving you any guarantees because there's no such thing. But what I am going to suggest is you ought to do this some more and see if this holds up, because you have an idea of what's going to happen when you touch this toilet. And I don't think that idea has been realized here in this bathroom. So, Mike, do I sound radically different than what you would be doing?
Radically different? No.
Okay.
I think if the question is, which I'm not sure if this is what you mean, but I've gotten this question a lot, which is like, well, this isn't very different from what I do. So is there any difference between emotional processing theory and inhibitory learning? And I would say there's a variety of pretty big differences, but which we can kind of go into, and we probably have a different opinion on it. But yeah, it's not, no, it is not radically different from what I would do. And there's, in the Venn diagram of exposure, there's a big area of overlap between different types of thing. If somebody's doing, you know, a variety of different types of exposure, there's going to be that center about repeated confrontation with something that's aversive. It's systematic. Maybe you're talking about sort of what the nature of the outcome is. That's going to be shared among how a lot of people do it. And then there are other differences, and that's maybe where the debate is, like, do those differences matter or things like that.
Yep, I would agree. I think Toland's 2009 paper about chicken hypnosis is a good place for us to start. That there's a bunch of different ways to hypnotize a chicken, most of which have tremendously overlapping procedures.
Sure.
But how we think about what's happening, the why, is probably different depending on your theory, and probably the how is influenced by the why. And maybe that's where the differences come in.
Agreed.
That's my sense. And in 2015, Michael Himley, colleague and friend of mine, wrote a paper called Let Truth Be Thy Aim, Not Victory. I think it's the best paper I've read in this field in 20 years, because it really explains when you would use X, when you would use Y. Why would you start exposures right away? Why would you wait? What would you be doing in the middle of your exposures if you're doing X versus Y? And having an overarching vision for what it is you think you need to achieve, and why it is that you're trying to achieve that, and how it is you're going to bring it about. I think it's a primer on answering these questions.
Sure. Sure.
And it's interesting. It does sound similar to you know, the papers that Mike has written. We're asking the question, like, what does the client need to learn, right?
Yeah, I'm terribly interested in that.
Or is it not similar, Mike? You raised an eyebrow.
I'm never satisfied when they habituate and I don't get any change in cognition. And frankly, I think those things are so highly correlated. I'm not sure I see too much of that. And I imagine the flip side is true also.
Yeah, I mean, so much like great stuff to talk about, and I mean, like, I love doing this stuff and chatting with everybody and hearing. That's my favorite part about being at UCLA and with Michelle's team, and like people come and visit, is we just like talk about this stuff all the time. Like we have a weekly meeting where we get to like hash things through, and it's sort of great. So I mean, I have a lot of thoughts. I mean, I don't know where you want to sort of take this. Like it sort of depends.
Well, I don't know if this is what you were going to focus on. At some point, I want to get to the therapist's role during exposure and what the therapist is supposed to do. And I think it's maybe a nice sort of segue from what Marty was just talking about.
That is a good,
so,
I'm
and like Mike, idea. You know, the last time you were in my office, we were talking about interoceptive exposure and your position. And I remember we had a big sort of kerfuffle in the office because people are like, oh, what? You're never going to do interoceptive exposure with your clients? And so let's talk about that.
Yeah, no, I don't remember what I said, because I think this is, Marty will agree with me probably on this. Like I certainly do interoceptive exposure with my client. Well, I briefly model it and then I have them do it.
But because you have to explain it.
You have to explain it, and you got to show them how to do it a little bit.
Yeah.
I don't do it alongside people because I don't want to act as in modeling. I don't want to model safety for the fact that they can't learn it on their own. And I'm, of course, cognizant that any type of exposure I do with people, when threat is kind of the outcome we're testing, that me being there is acting as sort of a safety signal. So I try to mitigate that as much as possible. And that's the other reason why homework is kind of really important. But the in-session practice allows me to sort of see how they're doing exposure and control things enough in a way that I'm trying to optimize what they're going to be doing outside of it. And I'm very specific about that. But no, I don't do it like alongside them continuously. One, it's not fun. I mean, I don't like doing it. I've done it hundreds of times and I don't like doing it. I don't like doing voluntary hyperventilation. So I'm not going to sit there and do it for a minute repeatedly. Like you can do that. But I also don't, I'm cautious about not trying to be too much of a sort of safety signal for somebody, which is going to decrease expectation and decrease extinction.
And I was going to make that guess as one of the reasons you wouldn't do it is because you're trying to maximize the inconsistency.
Yeah.
And so if you're doing a bunch of interceptives and you're dropping that down, you might be minimizing with the thing that you're shooting for.
Sure, exactly. Yeah. Not that everything is, a compromise, right? And so is me being there the worst thing in the world? No, because I get to control other things in exposure and they're still getting some extinction learning. I'm probably not as potent of a safety signal as them popping a Xanax, but it's still, I'm just trying to modulate and control things as much as I can. And there's kind of no such thing as the real perfect kind of exposure that taps into everything. I'm just trying to manipulate and control what I can control to sort of target that outcome.
And you can help demonstrate it by stepping up and stepping back too. So there are times when I'm going to be, as this woman described me, really chatty. And other times I'm going to pull back and say, all right, I'm going to chill back here, physically roll my chair back and say, let's take a crack at it this way and see what we get out of that.
Yeah.
I'm going to fuss around with that because I know that allocation of attention either towards their anxiety or away has some influence. And I want to teach them about that. But I don't want to, I mean, I think this is a point, maybe I have two questions for you. One is the role of distraction, if you will. I read Michelle's paper last night, from your paper too, 2014, and that you're very uncomfortable with distraction because you're trying to maximize that difference. I'm a little bit more inclined to say that's potentially a hierarchy step for me. So I might start with a little bit of, especially with kids, let's play a little game of checkers while we're doing this. Then I'll be quiet and see what we get as a sort of systematic move up. I also think this idea that we're all running around in emotional processing theory, forcing people to live by a hierarchy, that's also not true. Because the world is going to take your hierarchy away as soon as you leave my office. But in some ways, I'm trying to teach you the steps. I like to think that I make it somewhat predictable, not entirely predictable for the reasons you just described, so that you can learn the skills and so I can then step you up. It's like putting kids in a batting cage and turning the pitching machine on. I want to see what you can do at 35, 40 miles an hour before I put it to 70.
Sure.
Because if you can't, if I put you in there and I force you to hit 70 and you're a 12-year-old girl, my guess is that by the end of that practice, you're going to not want to come back again.
Yeah.
Which is another issue I think I would ask, which is, and I saw this in your writing too, which is you do a little bit of hierarchy work to make sure you don't lose them.
Well, the way I think this is, I don't know what your experience in supervision has been, Marty, but oftentimes when people are developing, not like experienced exposure therapists, but people kind of early on, they really are a little like walking on eggshells a little bit too much. And so their version of, I agree with you that I'm not going to do anything that's going to make the person drop out of treatment in the first couple of sessions, because then nothing's going to work. But I probably ask even and be willing to consider more intense exposures than a lot of other people who are probably just starting out. I think they're too tentative and they're too treating patients regardless of age, that they're more fragile than they actually
Yeah.
are. And I don't force anybody, of course, but I ask. I start by thinking what
Yep.
I think is going to be really helpful for them. And the first one might not be the toughest or the highest expectancy exposure that the person is going to do, but it's also not probably super watered down. And if it
Yep.
is, it's like one just to get the ball rolling, and
Yep.
then I start increasing it pretty quick. So there
Yep.
isn't, I don't use a hierarchy necessarily at all, but and we don't at UCLA, but we're certainly not going to be like, okay, what's your optimal exposure that's going to really do everything, and you have to do it the first time
Yeah.
you do it. Like, we don't
That's
do
helpful.
that.
I think that helps me understand better what it is that you're doing and not doing. I'm a little more inclined to work slow and work my way up, but then I
Sure.
want that pitching machine where it needs to be, which is where they're going to be pitching you when you're facing a live pitcher.
Yeah, yeah.
And that's
Yeah.
living in the world. I need to get you up there pretty quickly. I don't treat the patients like they're spun glass. If we do something and it winds up being harder than they can manage, this is John March 101,
Yeah.
which is John trained me to do this a long time ago, which is you just fall on the sword. You say, look, I thought we were ready for this. It seems like this was a bit much. I'm sorry, my bad. How can we build ourselves back up
Totally.
to get where we were going, but put some interim steps in there? What do you think you could do that's along this path? So I don't lose the patient, I don't lose the relationship,
Yeah.
but I don't change the truth. If you want to climb Everest, you got to summit Everest.
Yeah.
You can't do the bottom of the hill and think you're going to get where you need to get. And
Yeah.
I use that metaphor all the time. I'm very explicit about it. And I tell them I'm a Sherpa. I've climbed this thing more times than you can imagine. And I know where we're going to run into trouble. Maybe I'll get surprised here and there, but I don't expect to. So let's take this journey together and figure out how quickly we can get up there.
Yeah. Yeah.
All
I
right.
have a question
I
for
wanna-
both of you. Can I
Wait,
can I
hold
say
on.
it
Let me
real
just
quick?
briefly
Yeah.
say something
Nope,
from
that's
the
what I
chat,
asked.
and then
Go
I'll
for
give
it.
it to you. So Jennifer Lish is with us, which is the wonderful Jennifer Lish, and she's asking for the citation for David Tolan's article on chicken hypnosis and Michael Himley's paper. And so we're going to give you those
Yep.
citations afterwards. I'll put them on Facebook. I'll put them on YouTube. And so
Yep.
just let you know, Jennifer, for some reason I can't respond to her in the chat. I don't know why.
Good
But
stuff.
anyways, okay,
Well
Zach.
worth reading. Yep.
Yeah.
Yeah.
Turning to you, Zach.
So
Did you forget your question, or are you good?
I did for a second, but I think I got it.
All right, good.
Thanks. Just going back to what you were talking about of Marty, where you're like, if we did something that maybe it didn't go the way we had planned. Me personally, I've kind of developed the philosophy of no matter what happens, all exposure is good in a way. So even if they're like, I want to stop, there's still some significant helpful learning that took place.
Agreed.
And so I just kind of, to me, that seems like a nice kind of possible crossover between both of these, aspects that we're talking about of, okay,
Yeah.
so what, you didn't get to habituation. Maybe that's how we were operating, but we also know you were tolerating it for this much too.
Right.
So,
And I'm not. I mean, the idea of this 50% reduction within a given exposure,
right.
that's from Chambliss and Foa in 1979. Like there has been some development during this interim period. I'm not beholden to it. There's times I
No.
expect I'll get it. There's times I won't. And this is my question for Mike, which is
Yeah.
the people I can reliably say I'm not going to get it with are the discussed people and the not just right people with OCD. So my question is, how does your model apply to them? Because there is, other than I'm going to stay up this way forever, there is no consequence that you can disconfirm.
Sure. So I just want to say two things. The quick one to answer your question, and it's probably going to require more, is I don't think it does apply to them. And we don't sort of do an
interesting.
Yeah, that's when I have those patients, I don't do extinction learning at all because there's no extinction learning to happen.
Right.
So I don't even try to apply it. And I think it's a misapplication. It's a complete misapplication and a misunderstanding of our model to to try to apply it to that. It's
I
again,
Interesting.
hope
going back.
everybody just heard that who is
Yeah.
watching, because this is, again, right, one of the huge misapplications of
Specifically
the
for
word.
OCD too,
Yeah,
because
but
that's what we toil in a
kind
lot
of
with. So yeah.
go into that a little bit, but I just want to come
Yeah.
back and circle back at some point that I think it's worth circling back that I disagree with how our field of clinical psychology over decades has used the term habituation. And so I
Yeah.
want to maybe share a little bit about that. But yeah, to
Yes,
kind of
please.
go to Marty's question, like, no, I don't. When it's more about not just right feeling, asymmetry, there's, you know, a smaller segment of people with panic aren't really worried about something bad happening after they've had it so many times. They just find
Right.
it aversive. There's certainly, yeah, I don't do extinction learning at all because there's no biologically predicted outcome that I'm trying to disprove. And so my approach to exposure in those cases are I really am trying to enhance kind of coping self-efficacy around it and like
Okay.
Bandura. And I lean more heavily on coping skills in those moments because I want to give the person some efficacy and some agency around handling the anxiety and the discomfort.
Right.
I don't solely rely on them because I don't want every exposure to have them, but I use a lot of them. Whereas I think, unfortunately, people who don't have tons of experience in exposure or, you know, at the forefront of research or different things like that, they come away with this idea that every exposure has to be like super hard or difficult, and anything you do
Right.
to make it easier is like bad. And
Right.
it's
Right.
really bad if it gets in the way of the mechanism you're targeting. And sometimes it does for extinction learning, but when that's not the mechanism, why wouldn't I want to have the person do some diaphragmatic breathing? Why wouldn't I want
Yeah.
them to do coping
Mm,
statements? Why wouldn't I want
Yeah.
them to do anything? So I do that with those types of cases.
So you wouldn't be radically opposed to doing something that might have been heresy 30 years ago, which is to do competing response training with the not just right OCD people, which is give them a way to reallocate attention away from that discomfort and towards something
Yeah.
else, so they don't reinforce the urge by doing the behavior.
Yeah, I'm a little less willing to do like attentional shifting because I still want them facing the object
Fair
and like
enough.
they can cope. But in
Yep.
terms
mhm.
of, I mean, I love diaphragmatic breathing. I do it all the time. We all should be doing it more often. Like, why aren't we kind of regulating ourselves parasympathetically that way? And so, like, I certainly do that with people. I'm like, why?
Yeah.
This doesn't have to be torture. Why can't we make
Right.
it something that's doable for you, and afterwards like really celebrate how great you handled that, and that's the type of efficacy that I'm trying to build in that segment of patients.
And would
Interesting.
you shift into an act, because that's where I go, into an
Yeah.
act flare of, all right, is it convergent with your values to be washing your hands 50 times a day, even though even though you're telling me
Yeah.
it's just about how they feel, or should you try to do something instead?
Totally. Yeah, I think there's real value in that approach in trying to, you know, increase motivation, and for certain types of things like, yeah, can we act, you know, opposite action? Can we act opposite
Yeah.
to what the OCD is
Yep.
telling us and be like, no, can we do this? And can we do coping skills alongside of it? ACT may
Yep.
not do that unless it's like a decentering exercise. Like,
Yeah.
you know, nor am I arguing that some people within that community might, that it's all about acceptance, or it's all, I don't think
Right.
you can say in psychotherapy it's all anything, and people
No.
that do
No.
are selling something or exaggerating the evidence for their theory. But
Precisely. Yep. That's exactly right.
Anyway.
I think in large part, I think we're both more flexible than we might appear. And in the end, I'm not a theorist. I'm a Machiavellian pragmatist. I
Sure.
know exposure is going to be helpful, and whatever explanation I'm going to use to kind of bring you along into doing it, I'm willing to consider all possibilities. Although here are my working theories to begin, but if they're not working, then I better figure out why they're not working and pivot to something different.
Sure.
Yeah.
And
So,
just to point
yeah.
out, Jennifer says to Marty, may I borrow that I'm a Sherpa line? Great
Oh,
line,
by all
Marty,
means.
she says.
That is a great
I think
line.
we're all going to be using that from here on out. I'm a
Yeah.
I've been
Sherpa.
here before.
I
I've been up
wasn't
this
going to
mountain
ask.
before.
I was just going to take it, but sure.
Yeah,
like
it
it.
needs a proper citation now.
Yeah.
That's right. Trademark.
I'm sure I
Puts the
stole it.
TM.
John Martz used to say there are no new ideas. I think he's right.
Sure.
Really true. All right, here's what I want to get to next. And I have to say this because, I really was hoping that John Grayson would be here with us today. He's not here with us today, but in honor of him, I feel like we have to talk about this, the role of tolerating uncertainty.
Yep.
Which we talk about all the time on our podcast. So yes, thank you.
That's right. And so I'd like to start with Mike. Mike, what's the role of learning to tolerate uncertainty in exposure treatment?
I don't know. I mean,
I'm not sure.
That's a great answer.
It
What
probably
do you ask me
happened.
for? I don't know.
I think the mistake in our field, unfortunately, despite us all being psychologists or psychologically minded, is that all too often I think we do fall into like all or none or binary thinking. And
For sure.
I think when we're doing our writing on extinction learning, we're talking a lot about extinction learning, but I'm not saying that nothing else changes in somebody. I'm sure
Right.
as they have extinction learning, they're also increasing in self-efficacy. They're probably maybe learning to tolerate things. A lot of stuff's happening. That doesn't mean I think they're all equal. I do think for
Right.
a person and around certain disorders or subtypes of disorders, there's probably a hierarchy of things, of changes that need to happen, of what people need to learn. And even if tolerating uncertainty is part of it, when there is this Pavlovian association, just kind of hammering the point, my own personal belief, which is a theoretical and empirical hypothesis, is that you need to alter that predictive association to see the most amount of change. So given a choice for somebody who expects they're going to get Ebola by touching that toilet, like Marty was saying, if I could teach them to sort of tolerate, which I don't love that word anyway, like be able to sit with or just hold, manage that uncertainty, or learn that they're not going to get Ebola, I'm going to choose to learn for them to learn they're not going to get Ebola.
Yep.
So
Mike,
I'm
just
sure,
to clarify
yeah.
for a second, when you say that, I have a little knee-jerk reaction because
Yeah.
my thought is like, so are you saying that we're teaching people that the bad thing will not happen?
It depends on what the bad thing is. Like outside of social anxiety, a lot of the bad things that people worry about happening, or GAD, which is separate and also not an area I apply this a lot, but most of the bad things are really catastrophic things that have a super low likelihood of occurring. And yeah, that's kind of what I'm teaching them. In social anxiety, we all get rejected. Anybody who's dated or made friends like has experienced that, but still
Right.
the perceived likelihood is higher than it probably actually is. But yeah, I think there's zero likelihood that the person is going to get Ebola from touching the toilet seat and rubbing their face and mouth with it. And so, yeah, I do want them to learn that that's like not going to happen.
Interesting. I
the
think,
one,
and
but
this
you
is
go ahead,
maybe
Marty.
where I'm a little more inclined to the Grayson view. Is kids will sometimes ask me in the middle of an exposure, going back to contamination, we're sitting on a bathroom floor and touching stuff, and the kid starts to panic and says, "Are you sure this is safe?" And my response is, I like to use humor, but I also like to sort of laugh at the OCD a bit. I say, kid, I'm not even sure I'm going to be alive in 5 minutes. Like I like my odds, I feel pretty well, but there are no guarantees of anything. And then I continue on, as if to say that's not even a question worth considering. Like, am I sure? What am I sure of? Nothing.
Yeah.
Yeah.
Yeah. I think it kind of depends on the person for me and like what they're actually afraid of. But I think tolerance of uncertainty. First of all, I don't like the term tolerance at all. When I hear that, and it just seems like somebody is begrudgingly like through something, which I think is a crappy way to be. And that's what I would not want for a patient, to always feel like just they're trudging through a difficult circumstance. If that's what people mean by tolerance of uncertainty or distress, then I am not for that. Which is why I kind of lean more towards like efficacy, and I can reduce it and I can handle it. But if there's like a biologically significant outcome that I'm doing exposure to sort of test out the likelihood, target extinction learning, I don't really pay any attention to uncertainty or coping with distress. I'm like laser focused on the extinction learning. If there isn't, then I'm more about kind of coping self-efficacy and that you
Yeah.
can reduce how aversive this is. And I'm also not a big, like, I can tolerate uncertainty. I want them to be able to reduce the aversiveness of uncertainty and not just tolerate it. So I guess that's my position on it.
John Abramowitz, it was my former postdoc. I had a conversation at ABCT this past November, and I thought he put this really well, which is I always hate, he always bristles when someone says that, you're just supposed to sit with your anxiety.
Yeah.
He's like, no, that's not what I want. It's exactly the point you're making. He says, I want you to move with your anxiety. So I want you to go about your business. I want you to do things that you want to do and need to do. If the anxiety comes with you, that's fine. If it doesn't, that's okay too. But we're not moving to other things to get rid of anxiety. Like, that's not the point of moving to other things. And then you start swinging right into ACT territory, which is I'm indifferent to the discomfort. I'm indifferent to the presence of obsessions. But what's interesting about the ACT lit is when you look at ACT trials that have been done in OCD in particular, they ostensibly, theoretically, they're indifferent to the reduction in obsessions, but their data are not.
Right.
Like, I'm looking at data suggesting a 50 or 60% reduction on the Y box in their obsession score. So the reality is, when you go about your business and you stop wasting your valuable time doing compulsions, it's going to have some downstream effect on your obsessions, even if that's not at all what I was targeting.
Sure. And I 100% agree with you about ACT. And I think that speaks to the importance of being very clear about your theory and either standing behind it or not, or empirically. Like, when people continuously say like willingness is all that matters, and if they're just living a valued life, I think if you were to do that, and there'd probably be some decrease in stress, but theoretically, just as a thought experiment, if somebody was doing everything that they wanted to, but was still like panicking as they did it and was feeling horrible, I would not consider that a success. I think symptom reduction is worthy of pursuing. Even if valued action and decentering as a means to symptom reduction, but I'm a big fan of symptom reduction. I want people to feel less bad.
Right. And the way I put it to people is, it's like getting a song stuck in your head, which is every effort you make to get rid of it is going to maybe work temporarily and you're going to pay for it. Your better bet is to go about your business and let the world take care of it. And most of the time, the world will take care of it. If I come back to you in 2 hours, is the song still there? My guess is it won't be. And it probably won't be not because of the success you had in getting rid of it, but because of the success you had in allowing it to come along with you.
So if there's questions, I do want to just kind of, given that we have the audience, my little thing about habituation, because it is such a
do it.
Please do.
So in my opinion, that the field of clinical psychology, like all of us, has been misusing the term habituation for kind of decades to just mean and almost be like synonymous with symptom reduction, and it's not. Habituation refers, and I agree with you, Marty, that
this is the question I literally was just having in my head, so thank you. I was something related to this, so go ahead.
I totally agree with you that emotional processing theory and all the literature doesn't seek habituation as like a goal. I have other, I'd love, we should grab coffee or a beer sometime. I'd love to talk more about it. But habituation implies a process, just like extinction implies a mechanism or a process. And unfortunately, even the past couple of years, really prominent researchers in writing have said those terms are synonymous, and they're not. They're completely different processes with different mechanisms. The definition of habituation from the basic science literature is that you get a decrease in a response after repeated or prolonged confrontation with something that is not due to sensory adaptation or motor fatigue, but it's a non-associative process. So when we put people in the lab and you just shock them,
I get why people got that mixed up, Mike.
Yeah, exactly. It's a super easy kind of, when you put people in the lab and you shock them repeatedly, there's going to be some decrease in their reactivity to the shock. But it's a non-associative change. They're kind of getting used to that. So habituation, by definition, can only happen when learning and associative learning isn't taking place. So to say that somebody habituated when they learned that like a bad thing didn't happen is incorrect, because that's not the mechanism that was driving it. And I think our field, we did this in our RCT, we talked more about this, should get back to using those terms very separately and more for what they're in line with, because it confuses everything. When you say that somebody habituated and you're trying to enhance habituation, you go to the basic science of habituation to do it. You might be doing things that have nothing to do with improving the person because the decrease was due to something else. If the
Right.
decrease is due to I learned I can handle it, it's not due to habituation. If the decrease is learned that the bad thing isn't going to happen, that's extinction learning. It's not habituation. And so we should be clear on
Interesting.
terms.
Is your
No,
RCT out
that's
yet?
awesome.
Yeah, 2025, just like at the end of the year. I'll send
Cool.
it to
Can
you.
you send it?
Yeah, of course.
Awesome.
Please,
Oh,
both of us.
Zach,
Too.
did you have anything to say? It's so interesting, right?
It
I just
is.
want to say
No, this is
somebody
great.
made a comment, and this is,
Okay.
this is some of my reaction that I have is sort of thinking about my own patients. And one of the comments was from somebody who says even a low likelihood is a chance for an OCD sufferer. And so even that like minuscule chance
Mhm.
of
Like not
Ebola,
statistically significant is a chance. Like
Yeah.
right? But not
yeah.
even not statistically significant, because the problem
Right.
is that I remember getting into it with an ICBT person on one of the chats, one of the forums, where they were saying, well, you can make people feel confident that they didn't run someone over, and
Feel confident. That's different.
the problem is that even if we can temporarily make somebody feel like they didn't run someone over, what ends up happening is that we have 24-hour news cycle out there, and eventually in some subreddit forum you're going to read a news article that says somebody ran somebody over and had no idea what they did until the cops came to their house and arrested them for a hit and run. And I guarantee you that news story exists out there, and our OCD patients will find that news story and take that as meaning there is this shred, right? There's a
Sure.
chance. And
I
so
think
I don't know if we can disprove these, feared outcomes.
I hear what you're saying. There's a lot of things I would do with that patient who's sort of holding on to the real like possibility. One is much more exposure. We
Yep.
grossly underestimate as clinicians like how much exposure people need, and it's always a struggle with homework compliance, and it's one of the things. But even if we're just talking about the basic science of extinction, you need a lot of it and a lot of
Yeah.
repetition to really do it. So
Can I
more,
ask how
more,
much is
more,
a
more.
lot
I'm
for
sorry.
kids?
Yeah. How
Can
much is a
it's
lot?
probably how much is a lot?
Um,
I know it's
I mean,
not an
the
easy
rough
question.
estimate I, try to hopefully do that seems feasible depending is like, I try and get 3, practices per week. It depends if it's a really short exposure. I'm trying to do multiple of those times, 3 couple
Sure.
times a week. If somebody's super motivated or they get on momentum and they're doing like 4 or 5, that's like great, but super rare. And then that's for, not just like, oh, 10 sessions of an RCT trial, but I'm like months, to really push
Yeah.
it down past the I've improved, but still have moderate symptoms to get into mild symptoms. Like you got to hammer at it. You got to really
Yeah.
go. And
It's
that's
the
a struggle for all of
repetition.
us. But here's the thing with tolerance of uncertainty. I don't think what people mean in that case of did I hit somebody, that when they're not as bothered by it, I don't think they mean I've learned to tolerate that I maybe hit somebody. I think they are decreasing their belief and their expectation that they actually did
Yeah.
simultaneously. I
Agreed.
don't think it's just I am really tolerating the 80% likelihood that I hit somebody. They're not. They're sort of really believing and sitting with it's 99.9% likely I didn't. And so I think
But most patients, when they first come in, will tell
Especially
you
OCD.
there's a 99.9%
Yeah.
chance that I did not hit somebody, but
Yep.
that still does not extinguish that
Like and they will
fear for
say
that's
them.
because
intellectually what you
yes,
say makes sense.
but
But
that's
what I
because
Right.
feel is completely
they're
different,
thinking
right?
intellectually and they're not going like with their gut or like, I'm like, I
Yeah.
want to know, I want to convince your amygdala. I don't want to convince your prefrontal cortex. And so that's why I know this rationally, but I'm going to do tons and tons of exposure and do all the other things we talked about to sort of convince that stubborn, anxious OCD part of your brain, if you want to anthropomorphize it and
Yep.
externalize it a little bit, that's what I'm going to sort of do. Um, yeah, I guess I'm not a big fan of just tolerating uncertainty. I've come out and said it here on the, and now I can never take it back. That's not my
Well,
approach. So
I have a different take on what you were talking about because, one, I use learning to live with uncertainty as like my motto for OCD treatment, and I'm not offended by what you said at all. I think there's just slight semantics. I really do, but they do matter.
yeah,
Going back to your what you said about habituation and what I said earlier about things being watered down through telephone. We do have to I think pay attention to our language, what it actually means, how we're using it to describe what. And so I think that probably has something to do with this too.
and I'm totally fine with being wrong. Like Marty was saying, I mean, that's part of science is sort of
Right.
refining things.
Yeah.
But what you need to do is you need to do the studies and methodologically be able to separate those things. So you need to find paradigms and ways of showing that intolerance of uncertainty increased, irrespective of extinction learning or something else, to really say,
Yep.
oh, yeah, I'm improving
Good
tolerance of
point.
uncertainty, and that's what's driving it. If they're confounded or they're wrapped up, you're not being accurate with what the data is actually saying. And a lot of things are intertwined in a way that are not they're difficult to pull apart. It's possible, but people aren't even attempting those studies to really do it. And so I
Yeah.
think it's a little premature to say this is what's happening and this is what's changing when you haven't really used the methodology to justify that.
Well, there is actually, and I'm just thinking about a conversation I had with John. There is actually an intolerance of uncertainty scale. I don't know if that's exactly what it's called, but
Is
and
that
I
the
think
one,
it's
the
It is.
Patsy.
Canada
If
one?
John was
It
here,
is.
if John was here, he sent me this article, and it would just take me a while to find it. But
Yeah.
there are people that are actually sort of testing what happens when OCD patients come in terms of their tolerance of uncertainty and how that changes over time as a course of doing over the course of doing
Sure.
ERP.
But to kind of push back a little bit, what happens
Yeah.
in these studies is people choose to measure the thing they care about, and they don't
Yeah,
measure
that's true.
additional things to show that those other things kind of aren't changing or something is changing before symptoms, which is a criteria for something being a mechanism. So let's say I measure intolerance and uncertainty, but I'm not measuring self-efficacy, extinction learning, I don't know, a bunch of other different things. And all of those things are changing, but I'm only talking about tolerance of uncertainty because that's what I measured. Well, some of the
Right.
other things could have been changing and driving these changes that you're seeing. And if you're not using that methodology to disentangle that, you got to show specificity to be able to argue for specificity.
Right.
Makes sense.
Yeah. And, I think that, and we are coming up on the end of our hour, but I wanted to say that I feel like there are certain times when the application of intolerance of uncertainty becomes more important. Like for relationship OCD, I think it can be a really important concept for people to grab a hold of. And a lot of my ROCD patients by the end of therapy, they're like, well, I'm getting married, but I don't know if this is the right person for me. But the truth is that, as John always says, right? Everybody who feels very certain walking down the aisle, well, 50% of them are wrong. And
Sure.
Over
so
50%.
it's over 50%. So it ends up being really sort of a healthy coping skill to be able to say, I have uncertainty and I'm still going to proceed with this action, or else we're sort of frozen in our relationships.
Yeah.
That's what faith is.
Agreed.
Right. Oh my
Yeah,
gosh.
faith
Did you,
and
did you,
uncertainty tend to rhyme. That's what I usually say.
yeah. Did you see what was that? There was a movie about the bishops choosing the next pope, or the cardinals choosing the next pope. Did you guys ever see that?
I haven't. I would look at it. I haven't seen it though.
Yeah.
Yeah. Anyways, there was this wonderful quote which somebody said that the hope for the next pope was that that he was a man who had doubt,
Yeah,
because without
Mm.
doubt, there's no need for faith.
exactly.
I
Exactly
loved
right.
that. Yeah,
Sure.
loved
Spot
that.
on.
Anyways, so we do have to wrap it up because we're at the end of our hour. There's a lot more to say about this. I hope we would consider maybe having a continuation of this conversation sometime in the future. I'm sure we're
Yeah,
going to get a
would
lot of
you two be open
follow-up
to that again?
questions.
Because I mean, this was awesome.
Sure.
Yeah,
Yeah.
by all means.
Awesome.
Yeah.
That would be fun.
I think it was super informative, and we didn't even
Yeah.
get to everything today. We didn't get to
Right.
everything that we wanted to talk about. Well, we got to a lot of, I think, important things, set the record straight on a few things. Any last words that anybody would like to say?
I really enjoy this. I think when it comes to advancing some of these issues, I think part of the problem is that people aren't discussing and debating these things and thinking critically about it and being open to being wrong, or open to kind of admitting I only have this amount of support for something. And I think it's really important to do that, and to not be uncomfortable or defensive with differences. And because it's not chemistry. We can't be as certain as we can in chemistry. We're only sort of
True.
degrees of support, and we can maybe say certain things aren't possible and reject them, but a lot of it is kind of, well, I don't know. And if I think forums like this are helpful for just advancing that. So it was fun.
I agree.
Doris Kearns Goodwin wrote a book about the Lincoln administration called Teams of Rivals. And the idea there, Lincoln put together the people who he knew who would oppose his ideas in his cabinet, specifically for exactly what you just said. And that you're going to strengthen your ideas and you're going to move the field and the world forward only by doing that. We see the alternative. Teams of sycophants is not really as useful as teams of rivals.
Agreed.
Absolutely. Absolutely. And, so many of the things that we talked about today, I feel like it's a clear direction, future research, right? When people talk about the directions for future research, it's not nonsense. Like, these are substantial issues that we still have to look at and get clarification on, for sure. Okay, well, thank you so much, guys. I'm going to turn off the live feed. Feel free to stay on with me for another few minutes here, but thanks very much to everybody who's watching us here. And I think John will be back with us in a couple weeks if we can wrangle him in for our next episode. And but thank you very much. And let me get off the live stream.